Welcome back to Open Med School. In the last session, we have discussed about the lead systems. Today, we'll be discussing what are the components of normal ECG. Components of normal ECG. All of you take a bit of paper and start practicing by drawing. So, normal ECG will look like this as a P wave followed by electrical silence, URS complex, then electrical silence, the T wave, sometimes another wave, U wave. This is the normal appearance of the ECG. Let us look into the electrical foundation for this. So draw the part like this. This is the ventricle. This is the atria, right atrium and left atrium. Sinus node, the impulse is generated. It depolarizes the atrium, right and left atrium. Impulse reaches the AV node, where there is a delay. Divides into the right bundle, left bundle. It's the right bundle. Left bundle divides into an anterior division, posterior division, from endocardium to epicardium. The electrical impulses for the depolarization is going on. The P wave is due to the atrial depolarization. So P is atrial depolarization. Remember, it is not due to the atrial contraction or systole, it is the depolarization wave that is producing P. Following this, there is no electrical activity. That period is the PR segment. A P segment is isolated. And then comes the septal depolarization. It forms the normal Q. So the QRS complex is due to ventricular depolarization. This is a ventricular depolarization. Then again there is an electrical silence. That period is the ST segment. This is followed by a repolarization that leads on to the T wave. So T wave is due to repolarization of ventricles. This is followed sometimes by another wave, that is the U wave, that is due to the repolarization of the conducting system. This is the basic thing regarding the generation of the components of ECG. Hope it is clear to you. Now we will look into little more detail regarding each of these. We have mentioned that the P wave is due to atrial depolarization. So we know that there is a right atrium and the left atrium, which is the posteriormost chamber. The depolarization of the atrium is coming and it produces the initial part, the positive deflection. The left atrial depolarization is little late. This will again produce another wave, and both of them summated together to form the normal appearing P. So suppose the right atrium is enlarged, what will happen? The P will be tall. This is called the P pulmonale. So when the right atrial enlargement produces a tall P. Suppose the left atrium is enlarged, what will happen? The second component will be broad. So this will produce what is called a bifid P. called a P mid-range. Hope you understood the morphology of the P. Now, what should be the duration of the P? What should be the height of the P? The duration of the P should not extend more than 3 small divisions. We know that the paper speed is 25 small divisions per second. So, one small division is equal to 1 by 25 is equal to 0.4 seconds. So, the maximum duration of the P is 3 small division, that is 0.12. 3 is an important number. Remember, 3 small divisions. The height is also should be less than 3 small divisions. The P is more than 3 small divisions in height, you think that is a tall P. If it is broader than 3 small divisions, again you can see it is likely to be left atrial enlargement. The classical condition where you get a P mitral is the mitral stenosis, and P pulmonale is when there is a pulmonary hypertension. So this is something that you should remember when you examine the P wave. Then the PR interval. So the PR interval, we have already mentioned the PR interval is includes the P, there is until beginning of the QRS complex. In the electrical activity, the impulse arises SA node, it reaches the AV node, there is a delay, and the septum is depolarized. So this time, there is a depolarization of the atrium, the delay in the AV node, both constitute the PR interval. So the PR interval is from the beginning of P, the beginning of the QR. So this is the PR interval. So always remember the PR interval includes the atrial depolarization and the delay in the AV node. The major part is due to the delay in the AV node. So what is the normal duration of the PR interval? PR interval should be, again, it should be more than 0.12, that is 3 divisions. The same duration of the P wave. The maximum it should be less than 0.2 seconds, that is 5 small divisions. So two numbers 3 and 5. It should be more than 3 small divisions, less than. So when the PR interval is short, PR interval is less than 3 divisions, it is for short PR interval. One classical condition is the WPW syndrome. That is, there is a bypass tract bypassing the AV node, so the delay is overtaken. That is the WP, that you get what is called a short PR interval. Another condition is the LGL syndrome. About these things you study later. There is a short PR interval. Again, you can get in two conditions, WPW syndrome and LGL syndrome, Evin-Gano syndrome. So this is about the PR interval. So don't get confused with the segment. This is the PQ segment. PQ segment is isoelectric period. Now we take the, so we have said about the P wave. Now we take out the Q. The normal Q is due to septal depolarization, but we are talking about the QRS complex. So this is the P, the QRS complex. So the what is the normal duration? It should be again less than 3 divisions, 1, 2, 3. So the breadth should be less than 3 small divisions, that is 0.12. So the PVA should be less than 3 divisions, PR interval should be more than 3 divisions, QRS complex should be less than 3 divisions. Actually 2.5 division, that is 0.1 second. It's easy to remember that you remember it as less than 3 divisions or remember 0.1. So depending upon this, you divide the QRS complex into a narrow complex QRS. Narrow means it is less than 0.12 or less than 0.1, and a wide complex QRS. So wide QRS means the duration is more than 0.1, that is more than 0.3 or more small divisions. So when you are looking at the QRS complex, this is what you have to look for. Then the height of the QRS, when the ventricle is hypertrophy, the height is increasing. This we will study during when we are discuss about the ventricular hypertrophy. So here we are mainly concerned with the breadth. Remember, QRS complex should be less than 3 divisions. So when the QRS division, the QRS will be wide. Just we look into that. So the QRS complex is due to ventricular depolarization. So the ventricular depolarization, there is a, from the AV node, the bundle of is which divides in the right bundle, the left bundle which is dividing in the right and the anterior and posterior divisions. Think that there is a block in the bundle branch, either the right bundle or the left bundle. What will happen? The right ventricle is, there is a blockage. What will happen? The impulse will reach here, it comes blocked here. So what will happen? It gets depolarized from, take a circuitous pathway, bypass this region, and then it depolarizes. So what will, there is a delay because it is not passing through the normal conducting system, it is passing through the muscle. So the conduction speed is less. So what will happen? The ventricular depolarization gets prolonged. So this leads on to a wide QRS complex. The same thing happens when the left bundle is blocked. So it will take long time for the depolarization because the normal conducting pathway is blocked. Hope you understood the mechanism for the development of a broad QRS complex. Then comes the, so we have talked about the P wave QRS complex. Then comes the ST segment. This is again isoelectric. This is the place where you get changes of myocardial is MI. So we know the terminology is STEMI, that is ST segment elevation myocardial infarction. Then the ST segment gradually merges as the ascending limb of the T wave. So we can't exactly say where the ST segment ends and the T wave. So it has an asymmetrical, there is an ascending limb and a descending limb. The T wave is due to ventricular repolarization. Sometimes the T can be tall, taller than the QRS complex, or some people say more than 10 millimeters. We can consider it as a, or we call it as a tall T. Which are the conditions very good? Sometimes you get a T like this, a narrow base with a sharp upright. This is called something like a horn-like T. This is classic low when the potassium level, that is hyperkalemia. In the hyperacute phase of myocardial infarction, hyperacute even before other changes of myocardial infarction has not evolved, can develop this sort of a tall T. So remember these two conditions. Somebody comes with a chest pain and you get a tall T, consider it as a hyperacute myocardial infarction. Somebody is having a renal failure, undergoing dialysis, comes with a ECG with a narrow base, sharp. Think about the hyperkalemia. Then the T wave can be upright. Usually the T follows the direction of the QRS complex. The QRS is upright, T will be upright. If the QRS is predominantly negative, the T will be inverted. So this is called the concordant T changes. It is concordant with the QRS complex. Sometimes it is discordant. Discordant is usually suggestive of ischemia. Ischemic changes are seen in the T wave. So in ischemia, what will happen? The T gets inverted. The T wave inversion is suggestive of ischemic changes, except probably in V1 and V2. The ST segment depression, the T inversion can be of two types. One is symmetrical T. We have mentioned that the T has got a ascending limb, descending limb, but here you can see both are symmetrical. Symmetrical T inversion is classic of ischemia. You will get a asymmetrical T inversion in patients with ventricular hypertrophy, or some patient is on digoxin, you get a T like what is called inverted tick sign. So this is the tick, so just inverted. So this is what you will be looking at the T wave, whether the T is upright, whether the T is inverted, whether the T is tall, whether the T is symmetrical. If it is inverted, it is symmetrical T inversion, it is suggestive of a ischemic T inversion. Then we have already said about the ST segment. ST segment is this portion is called the J point. So we will be looking at the J point elevation. We will be discussing in detail regarding ST segment at the time of discussion about myocardial infarction. The ST segment can be depressed, the ST segment can be elevated. Depending upon the elevation, the ST segment elevation can sometimes called convex upwards, sometimes it is concave. This will be discussed along with myocardial infarction. Now comes the U wave. So this is a P wave, QRS complex, ST segment, T, and sometimes another positive wave. This is usually seen in mid-precordial leads. Mid-precordial leads, V2, V3 region. This is said to be due to repolarization of the conducting system. A prominent U wave is classically found in hypokalemia. So hyperkalemia you get told. And when that U wave is prominent, the problem occurs will be it will appear like this. T will be, and it will appear as an apparent QT prolongation. T will not be much prominent, and the U becomes prominent. It can be confused as a QT prolongation. That's significance. Again, remember a patient with diabetic ketoacidosis. You are checking the electrocardiogram. If the U wave is prominent, it indicates a significant hypokalemia, and you should be careful in administering insulin. You have to correct the potassium, then we go for insulin. Otherwise, patient can develop arrhythmias. So today we have discussed about the various components of the normal electrocardiogram and some of the common abnormalities that you have to look for in an ECG. In the next session, we will be discussing about the rate and rhythm identification in the ECG. Hope it was useful to you. Stay tuned. Thank you.